Hello and welcome to this video dealing with hip disorders in children. A crucial aspect in the examination of a child with a musculoskeletal problem involves the assessment of gait. Various gait abnormalities may be observed which could indicate the presence of a hip disorder. The limp diagnostic calendar is useful as it correlates age with the most likely cause of hip pathology. From age 1 to 5, there could be developmental dysplasia of the hip. Age 5 to 10, Perthes Disease, and age 10 to 15, slipped upper femoral epiphysis. It's also important to consider the chance that the patient may have an infection. On history, one should be alert to the presence of pain, previous trauma, and fever. Clinically, there could be swelling, redness, and warmth of the hip. Investigations required include a full blood count, ESR, and CRP. The likely causes would be a septic arthritis or an osteitis, and the general treatment involves incision and drainage with the use of antibiotics. Developmental dysplasia of the hip means that the hip joint does not form properly. It includes a spectrum of conditions such as dislocation at birth and acetabular dysplasia. It is more common in females. Etiological factors include ligamentous laxity. Females are more affected due to the presence of relaxin. Genetic predisposition, where it's more common in families, and mechanical factors in utero such as breech or oligogymnos, both of which decrease uterine size, and postnatally with swaddling. On clinical examination in the neonate, a positive autoantibody test or Barlow test should raise suspicion. In the walking child, a short leg and Trendelenburg gait can be observed, with the short leg above the greater trochanter, which is demonstrated by the Galizzi and Klezik's tests. Ultrasound screening is recommended for high-risk patients. On the AP X-ray, there will be disruption of Shenton's line. This is a line on the inferior aspect of the superior pubic ramus running inframedially along the femoral neck. It is usually smooth and continuous. There also may be displacement of the epiphysis in the upper outer quadrant. Management of DDH is dependent on the age. Less than 6 months, the patient is fitted in a Pavlik harness, which flexes and abducts the hip and still allows mobility. From 6 to 18 months, there is traction applied with a closed reduction and spica cast. If older than 18 months, an open reduction is performed and pelvic osteotomy. Outcomes are better if the problem is treated at a younger age. The complication associated with DDH is avascular necrosis. This may be caused by splinting at the incorrect angle of abduction and a tight open reduction being performed. Perthes disease is partial or total avascular necrosis of the femoral head. It is more common in boys. The cause is unknown. However, histological studies indicate recurrent infarction involving a vulnerable lateral retinicular vessel. The disease progresses through 4 stages. In the initial or necrosis phase, blood supply to the femur is disrupted and bone cells die. With the fragmentation phase, dead bone is removed and replaced with softer woven bone, which is very vulnerable. In the reossification stage, new stronger bone develops, and then lastly in the heel stage, bone regrowth is complete. Clinical features include a Trendelenburg and antalgic gait. There is also decreased abduction and external rotation of the hip. X-ray imaging requires 2 views, an AP pelvis and frog lateral. This helps with the staging of the disease, as well as assessing the amount of femoral head involved by using the Cattrall group. Treatment is controversial, but is aimed at protecting the femoral head whilst it is biologically plastic. Range of movement needs to be maintained for cartilage nutrition, and this is helped by physiotherapy. Containment is required, which involves abduction of the hip to protect the anterolateral femoral head. In terms of prognosis, 40% of patients develop secondary osteoarthritis after 50 years of age. Poor prognostic factors include age being more than 8 years. This is due to less remodeling taking place. Another factor is lateral femur head involvement. This results in a flat femoral head. SUFE refers to displacement of the proximal femoral epiphysis at the growth plate. The cause is unknown, but it is commonly seen in overweight boys of African descent. Theories suggest hormonal influences with an imbalance between growth and sex hormones, trauma that's seen in obese patients, and mechanical disadvantage. It's classified into acute, being less than 3 weeks, and chronic, which is more than 3 weeks. It can be stable, where the patient can bear weight with or without crutches, and unstable, where the patient cannot bear weight. Clinical features include hip and referred knee pain, an antalgic and mild Trendelenburg gait, and decreased abduction and internal rotation of the hip, with a tendency to externally rotate. Imaging requires two views, an AP and frog leg lateral. There is Chetowin's sign, where a line drawn along the superior border of the femoral neck, which is known as Klein's line, normally passes through the femoral head. This is where it does not occur in SUFE. There is also Kapner's sign, where the posterior part of the femoral head lies outside of the acetabulum. In terms of treatment, to prevent further slipping of the epiphysis, there is pinning in situ. Treatment also involves avoiding complications such as avascular necrosis, which may be due to excessive manipulation or due to an unstable and severe slip, as well as chondrolysis, which is due to persistent pin penetration in the joint or a slip. Thank you for watching.